I will very shortly introduce Jamie Vandenberg. I don't think I need to talk a lot about him. He's one of the leading cardiac ion channel experts in the world. Jamie is at Victor Chang Cardiac Research Institute in Australia. He will go into a more direction of electrophysiology, and his talk is focused on cardiac ion channel variants. He is using a high throughput system for that, in this case, SynchroPatch 384. And I'm very, very happy to welcome him here.
Thank you very much. Very pleased to be here and talk to you about the work that we've been doing with the SynchroPatch, which really has revolutionized the work that we've done over the last 5 years or so in my laboratory. So I'd just like to start by acknowledging the traditional owners of country throughout Australia and recognise the continuing connections to lands, waters and communities, and pay my respects to the Aboriginal and Torres Strait Islander cultures and to elders past and present. So the work that we're involved with is trying to tackle the issue of sudden cardiac death. Now, you may or may not be aware that about 0.1% of the population will have a sudden cardiac arrest every year. So in Australia, that equates to about 26,000 people. In Europe, that'd be about 750,000 people each year. And about 90% of those sudden cardiac arrests will end in death. Now, when it happens to a well-known sports star, a celebrity, there are big headlines around the world, but it is obviously much more common than that. And it is a big challenge. How do we try and prevent sudden cardiac arrests? So a lot of the public health campaigns are really focused about what do we do in the event of a sudden cardiac arrest? But if all we do is just focus on that acute problem, we're not really going to make a big difference to survival, because only 10% of people who have an arrest are actually going to survive. So our big challenge is how to prevent those arrests happening in the first place. So I'm part of an alliance in Australia called the Australian Sudden Cardiac Arrest Alliance, and we're trying to take a more holistic approach to tackling this problem. So rather than just focusing on the acute approach, what I'm going to talk about today is what can we do to better screen and diagnose patients who are at risk and try and prevent them having a sudden cardiac arrest in the first place. So the goal of our research program is to determine the functional impact of every variant in every ion channel gene associated with sudden cardiac death. So particularly for younger patients, the sudden cardiac arrests typically occur in the context of inherited heart disorders, and these are often associated with inherited mutations in cardiac ion channels. And so what I'm going to do is talk to you a bit about the work that we did, first of all, with HERG, and then I'll talk a little bit about the sodium channels. So as a bit of background, mutations in HERG cause long QT syndrome type 2, which has an incidence of about 1 in 5,000, and an overall mortality of about 0.3% per annum. So in terms of the variants in HERG that cause the disease, that equates to about 0.02% of the population that have a disease-causing mutation, compared to about 0.8% of the population who have a rare variant in their HERG potassium channel gene. And obviously, most of those are going to be benign. And obviously, a total of about 22,000 possible missense variants. So it's obviously a grand challenge in terms of how do we characterize all of these variants, both the benign and the pathogenic, so we can differentiate between those patients who are at risk and those who are not. So the challenge that we've tried to address is how to increase the throughput of functional genomic assays for cardiac ion channels. Now, the traditional approach has been to do patch clamp analysis, whether that be in native cardiac myocytes, iPS cells, or transfected heterologous expression systems, using a manual patch clamp system, a cell at a time, a variant at a time. And it's obviously a very slow and laborious process. But obviously, with the automated patch clamp system, we can increase this throughput by orders of magnitude. Now, in recent years, the clinical genetics communities have come up with various guidelines for how to develop the assays to do functional studies, because they recognise that functional assays for particularly rare diseases are particularly important, because it can be difficult to garner enough clinical data to confirm whether a variant is or isn't the cause of disease. And this just summarises some of those key features of how to do the clinically validated functional genomics assay. And I'll go through each of these processes and how we adapted those, to develop the assays for assessing variants in cardiac ion channels. So the first thing we did with the HERG assay was that we generated a plasmid that had both the wild type and the variant. So we could look at heterozygous expression of the variants. And that was using an IRES expression system so that we had a consistent ratio of expression of wild type and variant for every different variant that we generated. Secondly, and perhaps this is the most important thing, was using this flip-in expression system so that when we transfected the cells with our mutated ion channel variants, every plasmid gets inserted into the same place in the genome in every cell every time. So that means that if you see a difference in the level of expression of one variant compared to another, you can be confident it's not because they've ended up in a different area of the genome, which might be more or less capable of expression. They've all been in the same place. So if there is variation, that's got to do with the variant itself. We then grow these up in large-scale tissue culture, and typically we do 12 flasks at a time, which is a wild-type positive control, a null or negative control, and then 10 variants each time. And that fits nicely into the 384 well format for the synchropatch experiments. So I've just listed down here below a series of the references that describes the development of these assays. So I'm sure any of you who have done synchropatch recordings will be familiar with this sort of output, which comes up in the data control software. And you can see the way that we're formatted it with a positive control and the first two columns, the negative control in the last two columns, and our 10 variants in the middle. Now, the first thing that you'll notice, and it's interesting when you look back through the literature, this is a very well-described, well-known phenomenon, but largely sort of skated over, and that is the extent of cell-to-cell variability in the level of current density, even if you look at native cardiac myocytes. So one of the first things we had to do is just establish within our system what was the cell-to-cell variability so that we could establish the sort of power calculations, how many recordings you need to do to be able to compare one variant to the next variant. And this was the standard quality control processes that we used. One of the issues with the synchropatch is that often the series resistance, etc., is not quite as good as you can achieve in manual patch clamp. So we had to introduce more stringent quality control, many more recordings to make sure that we could get robust data from each variant. One of the other things we need to do is to establish the technical variability. And so this is just showing an example of the results that we obtained from our wild-type positive controls versus our negative controls across 24 different plates. And so you can see the level of variation that you get from plate to plate, and this might be due to slightly different temperatures in the lab, different conditions associated with how you've set up the experiments, etc. But it's important that you can't eliminate this variability, and it's important to know exactly what is the level of variability so that when you're doing your recordings and doing your analysis, you can be confident as to what is a real difference and what isn't. In terms of applying that to functional genomics, probably the most important step is this benchmarking against known benign and known pathogenic controls. So when you come to look at a variant, it's not, what isn't critical is how much it varies from wild type, but whether it varies from the level of function that you could see or that you do see in the benign variants that exist in the population. So we know there are hundreds of benign variants. And some of those benign variants have slightly higher levels of function, some have slightly lower functions than wild type, but all those benign variants we know are consistent with a normal lifespan, no increased risk of cardiac arrhythmias. So the absolute level of wild type is not the critical parameter, it's the range of function that you can observe in benign control variants that matters. So we establish those ranges for the benign variants, and then we can look at a whole series of known pathogenic variants and see what their level of function is. I should say the parameter that we're looking at here is just the level of current density, to the extent to which a mutation causes a trafficking defect, which we know is the major cause of disease in long QT syndrome. And as you can see, there's a clear separation of the pathogenic variants from the benign variants. There's just a few more examples of benign control variants obtained from different data sources versus our known control pathogenic variants, to show you can see this nice clear separation for known pathogenic and known benign, so that you know when you now look at an unknown variant or a new variant, you can see, does it fall in the range of benign or does it fall in the range of pathogenic? Now, we've developed this assay and applied that to a number of large-scale cases. The first time we looked at every possible single nucleotide variant in exon 2, so that was 460-odd variants. And as you can see, there are a couple of residues where every variant gives you a relatively normal function. And there are also a couple of variants like this one here at glycine 71, where every variant we looked at actually caused severe loss of function. But it was quite variable across the exon, as you might expect. So the next thing we did was look at this to see how it applied to all those variants that have been observed in clinical scenarios. So these are patients diagnosed with long QT syndrome who are then found to have a variant in their HERG potassium channel gene. And the question we wanted to ask was, is that variant the specific cause of disease in these cases? And what you can see is you get a whole series of them. This is down in the PAS domain, a large portion of them in the POR domain region, where they cause severe loss of function. Whereas the variants in these sort of interleaker regions, the proximal N terminus, the distal C terminus, they're more often not really associated with significant loss of function. And then one of the most gratifying results from this study is we then looked at, can we correlate the level of loss of function that we observe in the HERG potassium channel, at least as determined by the peak tail current, and whether those patients have cardiac events, syncopal episodes, aborted cardiac arrest, or indeed death, versus those that have events versus those that didn't. And if you look at those that have the event, almost all of them have a severe loss of function mutation. There are a few up here, scattered up here, but this is a much smaller proportion than the ones that are down here. Whereas you look at the patients that have not had an event, you can see they've got a much broader distribution. Sure, there are some that have severe loss of function, many more that have this much lower or less loss of function. To the extent that we can now be confident that if you've got a high loss of or a significant loss of function, you do indeed have a much higher risk of having cardiac events compared to those that have lower or milder loss of function. So I'd now like to move on to our sodium channel assay and specifically looking at loss of function mutations which are associated with the Brugada syndrome. So the incidence of sodium channel associated Brugada syndrome is similar to long QT2. So it's about 20% of all Brugada patients. It's about 1 in 5,000, a similar overall risk. But obviously there are more variants in the general population because it's a much bigger gene and a much larger proportion of variants still to study. And about or similar or slightly higher level of those variants that are currently classified as variants of uncertain significance. So this just shows some examples of some of the sort of quality data that you can get for recording sodium currents. And those of you who are familiar will recognize the typical features of cardiac sodium channels. We use these standard assays where you can then measure the current density at whichever voltage you decide, but you can also measure activation curves, inactivation curves, and I'll come back to that in a moment. So when we did the benchmarking for this assay, what you can see is that you get all of your benign variants line up in this region, but we had one that stood out. This was the S216L. Now, it's an interesting variant that some people have classified as a risk allele, and maybe it's not completely benign, although it is relatively common in the population, which is why it is typically classified as benign in most genomic cases. But you also have a couple of these variants that actually appeared, they're known pathogenic variants, that they appear to have normal expression levels. So that the phenotypes associated with variants in the sodium channel are a bit more variable than what we see in the HERG channel. But as I said, the advantage of using patch clamp type assays to be able to assess all these variants is you can then look at all the gating parameters as well as the trafficking and current density parameters. And this example shows an example of a variant that has a right shift of the steady state activation. And you can see there are a few of the variants which are really quite markedly shift compared to wild type and the benign controls. Similarly, there are some variants that have marked shift in their steady state inactivation compared to the benign controls. and a couple of them that have really significant shifts in their recovery from an activation. And these are some of the variants where at a simple steady state baseline level, they appear to have a normal current density. But if you start to pace a bit more frequently, then you'll start to elicit the loss of function that is associated with the Brugada syndrome. And so what we then did was try to integrate all these gating parameters to see if we could come up with a single assay that would help sort of classify each variant as quickly and as sufficiently as possible. And so what we're comparing here is the effect of the peak current density when we measure from a holding potential of -120, when all the channels are going to be closed, but have recovered from an activation, so we can see the full current density, versus the current density you get when you have a holding potential of -90 millivolts. It's a bit close to the physiological resting membrane potential of a heart cell. But it also will, for those variants that have enhanced inactivation, they will have started to inactivate at -90 millivolts and so give you a smaller current density. And you can see that with a few examples here, particularly these R1631 variants, where from a holding potential of -120, you can see they have reasonable current densities, perhaps obviously bits less than the wild type, but in the sort of range of what we've seen for our benign controls. But when we use the -90 millivolt holding potential, you can see the inactivation has started to come into play, and these variants now have much lower current density. So you can start to see those variants as being loss of function from this single one-step assay. So this was the final plot that we were able to generate in terms of looking at characterizing benign variants versus the known pathogenic variants. And it's not quite as good as the HERG assay, but we're still getting a very good separation of the pathogenics versus the benign controls. So again, as with HERG, we've now gone on to look at, this isn't quite every clinical variant that's been described, but all the variants that have been described in the European, pan-European cohort. So this is about 250 different variants across a cohort of about 600 sodium channel positive Brugada syndrome patients. And what you can see is that in the transmembrane regions, they tend to have a lot of loss of function. In the inter-domain linkers and the cytoplasmic regions tend to be where there's lots of this sort of relatively normal function, and all these loss of function ones correlating with the poor domain, which is what you would expect to see. Although it is important to point out that we do have a few of those variants in the transmembrane domains that do appear to have normal function. So we can't just assume because something is in a hotspot region that it is necessarily a significant loss of function variant. Now, in terms of applying that to the clinic and how useful that could be, what we've shown here is for these 252 variants, how they would be classified if we just use clinical parameters, and then this is the alpha missense in silico prediction tool. And as you can see that just with those clinical and alpha missense or in silico tools, you're going to have most of the variants are being classified as VUS. But if on top of that, the best current in silico clinical data, we add our functional data to it, we now see that we can now classify nearly half of our variants as either being pathogenic, likely pathogenic, and a few of them that are benign. So we can go from a scenario where something like 85–90% of those missense variants were classified as VUS to a situation where it's now only about 50–55% of them that are classified as VUS. And similarly, we haven't yet got the wealth of clinical data that we had for the long QT cohort, but what we can see is that in terms of looking at penetrance, so to what extent a proband with the pathogenic variant will have children that are also going to have the syndrome. If you've got a severe loss of function as defined by the Z-score of less than -4, so more than 4 standard deviations away from the mean of the benign, then the odds ratio of that being a highly penetrant variant is 300–1. Whereas as you get these milder loss of functions, the penetrance goes down. And finally, when you get to these variants which have range within the sort of range of the benign scenario, that their penetrance is in fact almost, negligible. So I might finish there. Particularly just want to thank the team at the Victor Chang, led by Andy Ng, and his team of Joanne, Check, and Evie, who've led all the functional genomics work in my lab at the Victor Chang, Connie, Jess, and Adam, who have helped us set up some of these assays. And of course, this work isn't possible without very extensive collaborations. And this just highlights the major collaborators that we've had, but it includes people from all over, multiple centres in the US, the UK, and Europe, but particularly Brett Cronk and Andrew Glazer and Matt O'Neill at Vanderbilt, Kate Thompson at the University of Oxford, that have helped us to establish these assays. And finally, just like to thank the New South Wales Health, NHMRC, and the MRFF who have funded this work. So thank you very much.
Thank you very much, Jamie. This is amazing presentation. Thank you very much. Do we have any questions for Jamie here? All was clear. I'm actually really amazed about, you mentioned in the beginning, how many known people have it and how much attention that brings, but actually it is a very, very common thing. Do you think that assays like this could also be used in diagnostic purposes and then we test people in the future?
Yeah, absolutely. So, one of the next levels, we're focused on applying this to patients who clinically defined to have these disorders, whether it be long QT, Brugada syndrome. And so, there's a high likelihood that it's going to be a abnormal variant. So where, the greatest return for your money is going to be. But the biggest use of genomic sequencing is actually people that have genetic sequencing for all sorts of other reasons, whether it be a cancer diagnosis or a neurological problem. And many of those patients are going to have variants in their sodium channels, their HERG channels, their IKS channels that will be found inadvertently. And being able to determine which one of those are benign bystanders, which will be the majority, versus those that actually are a genuine high risk, that's a big challenge. And that's going to become an increasingly important challenge as more and more people get sequencing done and sequencing continues to get cheaper and cheaper. So having that ability to actually either measure efficiently or having prior measurement of all those different variants catalogued in a database that people can readily access so that they know whether a variant's benign or pathogenic, it is going to be increasingly important in the years to come.
Yeah, thank you. Okay, yes, Jan, please. And then we have another question from Tom online.
Yeah, thank you very much. I was wondering, this loss of function mutation that you showed, where it looked like the steady state inactivation was very strongly increased. Is that the typical ball and chain mechanism? And what is the precise reason why it is so strongly increased in these mutants? Do you know that?
Yeah, so it's a variant that occurs in the fourth. I'm sort of have to double check, but I think the one we were talking about is the fourth transmembrane domain of the fourth domain, which is that domain that is associated with the inactivation process. So it's not part of the actual ball or the chain, which is that cytoplasmic.
The IFM.
But it's more in the sort of the voltage sensor component that links and influences the movement of that ball and chain.
Okay.
Thank you. Maybe Ali, could you read Tom's question?
Okay, this is a question from Tom from Nanian. What could be the precautions taken for those people who carry a pathogenic variant so they don't suffer from a cardiac arrest?
So it depends very much on the particular condition. So broadly speaking, in the long QT syndrome patients, the vast majority of them will have a very good response to beta blocker therapy. And the beta, if you can get your patients to tolerate taking beta blockers, that will reduce the risk of a cardiac event, at least in long QT1, by probably over 95, maybe even 99%. Long QT2, perhaps not quite as much, but it's certainly in that vicinity of 90%. The long QT3 is a little bit harder, but they're not as responsive to beta blockers, but they probably respond better to sodium channel blockers because the long QT3 is a gain of function. The Brugada syndrome is much trickier. Brugada syndrome is a difficult condition to treat because it's obviously a loss of function of the sodium channel. So you can't, there aren't really good modulators of sodium channels to actually increase the activity of the sodium channels. But there is some people have shown benefit from treatment with quinidine or some of these drugs that actually block the ITO current, so that sort of counteracts the sodium channel during the initial phase of the action potential. But the Brugada syndrome is the one that is much harder to manage, and many of those patients will end up having to have a defibrillator if they are genuinely Brugada syndrome positive, and particularly if they've had symptoms.